Super. Thank you all. Thank you all very much for coming. Is the mic on? Can everybody hear? It's just a delight to be here, and thank you all very much for coming out early on a Friday morning. Ava, thanks so much for the introduction. It's just lovely to be back. So to start the story, I guess the first question was how does one end up in public health? And it's a short story, really. I was in medical school and had a grant from the U.S. Public Health Service that put me through medical school. And the terms of the grant were that in exchange for the time they paid me and put me through med school, I would do time for the U.S. Public Health Service. And there was a list of sites that came out where one could go, and most of them were in Texas, in the border, or parts of Los Angeles or New York, North Dakota. But there were 2 sites in Micronesia. And when the list came out, I raced to the sites in Micronesia and ended up in the Pacific Islands on an island called Truk. You can see it there. It's in the middle, frankly, of nowhere. It's an island state. The Federated States of Micronesia is an island state of 4 states, and Truk is about the size of Texas. And I lived on the island there where the star is, the island of Moen, in a lagoon. And was in 1986, when I got there, the very first obstetrician and gynecologist that had ever practiced on the island. It was an island, there was a hospital there that was populated mostly by doctors from the United States. And for most of my 3 years there was just taking care of patients. I was, for 2 years there, the general surgeon because there wasn't another general surgeon, and that's when I was doing my appendectomies and amputations and the other things that one only learns from a book while you're doing them. It was a beautiful island. It's the kind of thing that you picture. You know, it's beautiful. This is scenes from the beach where we used to sit when we weren't practicing medicine. These were the homes in which people lived. But it was an amazing place to spend time. And I remember one occasion where I was called down to see somebody who had gotten a coral scratch. And they said, it's a very important person. Would you please come down and see him? And I went down, and there was the junior senator from Arizona, John McCain. And started a long relationship with John McCain, and he brought diving gear to the island and a decompression tank because the big activity on Truk is scuba diving. Scuba diving is the center of activity because in 1944, in Truk Lagoon, the Japanese Navy was based there, as much as the U.S. Navy had been based in Pearl Harbor. And in 1944, the U.S. sunk most of the Japanese fleet. So I spent the better part of 3 years doing this. This is life in Truk. This is what you do on Saturdays and Sundays. And I don't know if you get the full picture of the color, but it is a dive site of note for everyone around the world. And these are the kinds of things we did to spend our time. And these are the Japanese ruins we used to go down and dive on. It was a wonderful way to spend 3 years. It was a wonderful way to become introduced to public health and understanding that you can do more by taking care of populations, not individuals. And that became really the focus of my interest, not taking care of individuals. There are lots of good doctors doing that, and I'm always grateful when I can go see one of them. But my interest became taking care of populations. Over to Rich.
Thanks. Again, thanks, Ava. It's great to be back in Williamstown. My path to public health was a little different than Mitch's. After Williams, I took a year off before medical school and traveled around the world and came back with a sense that my career would be global, that the ability to have impact, if you're looking at public health, populations at greatest need were around the world. And that was something that I kept in my head. But I didn't really fall in love with public health until I fell in love with diarrhea. And it's been a long love affair. I spent a year, as Ava said, in Bangladesh working on studies of diarrhea, impact of polio vaccine in children who have diarrhea, looking at cholera. And then I came back to the CDC to learn how to be an epidemic investigator. They have a great program. And the branch there that has the most fun, has the most outbreaks, is the diarrheal disease branch. So I took a position there, and it was 20 years ago this year. I was working the phones. I'd been on the phones for about 3 months waiting for a good outbreak, and none had come. And then the phone rang, And it was Massachusetts State Health Department. They had 6 kids in Boston who were in kidney failure. And it was from E. coli. This is a similar strain to what's causing the big outbreak right now in Germany. And so I talked to my boss in Atlanta. They put me on a plane to go to Boston. Arrived in Boston, spent the next 3 months working up this outbreak. I traced the E. coli to a small farm stand in Swansea. And it was the first E. coli outbreak linked to apple cider. And I did this all by asking people questions, asking sick people what they ate, asking well people what they ate, figuring out the difference, and it was apple cider. And it was amazing. I came back to Atlanta with this result. I came back to Atlanta with a wife. It was like the perfect outbreak. And so I was hooked, and that got me going in public health. We're going to transition and talk a little bit about how we got from our entry in public health to where we are now.
But before I do that, what happened to the apple cider industry in New England after that?
Well, that's, another story. The apple cider, I had worked in apple cider as a kid on an orchard. Apple cider is made not from those pretty apples you see on the label. It's made from the apples that fall on the ground that you can't sell in the market, which are rather disgusting apples. And so I had paid a visit to the apple cider manufacturers. They were having a conference during this time. And basically, they weren't very happy with me and my investigation. It's changed so that now apple cider has to be pasteurized if you're going to drink it. So it's safe to drink your apple cider. It's not quite as safe if you buy it from the farm, but pasteurized is fine. Yeah.
Great. So leaping ahead to where I am now, how did I get to be where I am now? Well, as Ava explained, in the 1990s, I moved to San Diego to take care of a population of women who were, for the most part, from Mexico, who couldn't get care. None of the doctors wanted to provide care for them. And one of my associates in the practice was taking care of women who had HIV and were going to the university hospital, and they were pregnant with HIV and needing care. And back in the early 1990s, there was very little we could do in the United States for anybody who was infected with HIV and pregnant. There was very little we could do to prevent mothers from transmitting HIV to their babies. But Jeff was in the clinic seeing patients, and he was HIV positive also, and he got sick. And he asked if I would take care of his patients when he went in for medical care, and I agreed to do that, and Jeff never got better. Jeff died in 1991, and that's when I started taking care of mothers who had HIV and were pregnant, and found an extraordinary group of mothers who were in many ways very heroic, that they knew that there was nothing we could do for them. And through the course of the 1990s, we would talk to mothers, we would educate them, we would tell them whatever we could, but there was very little medicine we could give them until about the middle of the 1990s, when one of the studies in which we were participating demonstrated that a single drug called AZT, if given to the mother during the pregnancy and given to the baby after delivery, could reduce transmission by 2/3. That was in 1994. And then in 1996, there was a series of tests and new drugs that came out that were extraordinarily effective, keeping people with HIV alive, turning HIV into what it is today, a chronic illness. And from 1996 until I left, at the end of 1999, there wasn't a single mother that infected their baby. So every single mother with HIV had an HIV-negative child. I was interested in seeing what else I could do in the realm of public health. And as Ava had mentioned, back in the 1970s, I had been first an exchange student in Cape Town, and then I had taken a break from drinking beer at Williams to go back to South Africa and work in hospitals, and wanted to go back to South Africa again with my family to see what I could do about an epidemic which was growing, becoming essentially a pandemic on the continent. And so 1999, moved back to South Africa to take a position at the University of Cape Town to develop their HIV programs for HIV-positive mothers. Now, to appreciate, in the United States, HIV is eminently treatable. And just in Africa, there are about in the world today, there are about 1,100 children infected with HIV every single day. Of those, less than 1 a day is infected in the United States. About 1 child a day is affected every day in Europe. It gets worse. About 100 children are infected every day in Asia and the Pacific. And about 1,000 kids every day are infected in Africa. And so this is the epicenter. This is where the infection takes place. And essentially, there are 22 countries in the world which represent 90% of the HIV-infected mothers in the world. 21 of those are in sub-Saharan Africa, one is in India. And this is really where we center our efforts. This is where we want to provide care. Now, the challenge in providing care is no longer the drugs, which are very affordable, and it's no longer the tests, which are accessible, but it's about the healthcare systems in many respects. And what you find is, if you look at this, Africa has a disproportionate share of the epidemic. You'll see how bloated Africa is. But it also has a disproportionate share of the care providers. And if you look at that little sliver there, that's the doctors and nurses working in Africa today. And essentially, Africa has 25% of the world's disease burden and only 3% of the healthcare providers. So what happens is that while people come to health facilities for care and while the drugs may be available, there's just simply aren't enough providers to meet their needs. Doctors and nurses don't have the time to explain to patients, to support patients in these interventions which are increasingly effective. Remember, in the United States, less than 1% of mothers who are HIV positive will infect their babies. Without treatment, 40% of babies get infected. And so we needed to find a way to try and create a new model of care that would make health services more accessible to patients, more acceptable to patients, and change the dynamic in terms of how we can deliver services. And so in 2001, I started an organization called Mothers to Mothers. And the principle of Mothers to Mothers is relatively simple. We view mothers as the community's single greatest resource. And what we do is mothers who've come through the medical programs, mothers who are HIV positive, who've been patients, are brought back into the healthcare facilities as healthcare providers. They're trained and they're paid to work side by side with doctors and nurses. And while the doctors and nurses do the diagnostics and administer the drugs, the mentor mothers, the staff who work for us, provide the education and psychosocial support. Because ultimately what we're trying to do is drive behavior change. It's not about giving anybody a drug. We all know that. Those of us, who aren't exercising as much as we should, or smoking, or engaging behaviors that don't contribute to the best possible health. It's not about the doctors anymore. It's about how do we change behaviors. And the work in Africa really, in the advent of programs that can provide drugs and tests, is how do we change people's behaviors? And to be honest, working in a clinic, I was a white doctor who spoke English, who didn't have a notion of what it was like to be living in the culture. I couldn't connect with my patients. And if I wanted to talk to a patient in the hospital where I was working, they would bring down a cleaner from up on the wards who would translate for me. Because in that hospital, neither the doctors nor the nurses spoke the language Xhosa, which was the language most of the patients spoke. So when you have a cleaner who might even be a man trying to explain to a woman how to breastfeed her child to get the best possible outcomes, you know the system's not going to work. And this was true across the entire continent. And so, if you can imagine, what does it feel like? You come to a clinic, you're a woman. You come to the clinic, you find out you're pregnant and you're delighted. And then you find out that you're HIV positive. And all you know is that you're going to die, and that your baby's going to be infected, and the baby's going to die. And you're devastated because there's no one you can tell, because of the stigma associated with HIV is enormous. And yet when you come to a facility where we have mothers to mothers, what you encounter is a mother like this, who will stand up and talk to you and say, I'm HIV positive. I was where you were 6 months ago. I had a baby that's HIV negative. We can educate you, we can support you, we can give you everything you need to ensure that your baby comes out negative and that you stay healthy and alive to raise your children. And that's what the program does. It works to put mothers living with HIV, our mentor mothers, together with mothers who are pregnant or who've recently had babies, to give them all the education and support they need so they can have the best possible outcomes, so that their babies are negative, so they can stay alive to raise their children, and so they can help fight the awful stigma associated with HIV. They meet with mothers in groups. This is in the antenatal clinics. We're in the delivery wards, where we go to the postnatal wards after mothers have given birth to educate them before they go home. We explain to them about how to take care of their babies, how to feed their babies properly, family planning. It's all part of the program. And it's about a program that looks at comprehensive health for mothers and newborns and children. These targets to improve the health of mothers and children everywhere. Our mothers are trained for 2 weeks. So you can imagine, if you invest 6 to 10 years in training a doctor, 4 to 5 years in training a nurse, you get a mentor mothers trained in 2 weeks. And what's interesting is our staff are so well trained and so regularly trained, we train them every year, that doctors and nurses start to view them as experts. So the new guidelines that come out are first taught to our staff, and doctors and nurses who used to be providers for our mentor mothers now come to them as experts and say, what's the treatment today? How should we be taking care of this mother? And you can imagine how empowering that is to a mother living with HIV who maybe has never had a job before and now has status and is a professional in a healthcare facility. The program started back in 2001. As Ava said, we're now in 9 countries. We have 714 program sites. We're reaching 20% of the HIV-positive pregnant women in the world today with this program, which is extraordinary. And as much as I'd like to speak on behalf of the mothers, it's always better to let them speak on their own behalf.
When I was pregnant, I think it was my 6 month or thereabouts, I came here to the clinic. I found out that I was pregnant.
Last year I was pregnant.
I got tested for HIV.
For the health of my child.
And I tested HIV positive. I was very hurt and I was crying.
I couldn't even believe it. I wanted it to be redone. They did it again and they showed me. They told me it's not going to change. It's like this. So it's better if you accept it.
I thought I'm going to die maybe tomorrow or a few months later.
I wanted to hide.
Maybe in a few days or a couple of months I'm going to die. Maybe even before I bring the baby, whatever, I'm going to die. That's what came to my mind.
I was crossed because it happened when I was in 7 years in the marriage, when I was diagnosed.
I can't tell anyone about it. It has to be myself, and I can't even tell my husband, because my husband has always told me, if you can test HIV positive, it means you are the one who brought it along in the family, and you've brought a curse in our family. It's a curse. So, and I can go and kill myself. I can go to the train station, go to the railway station and kill myself.
He actually came to my place and said, I have come to apologize because I had known my status. He had known his status since 2001.
So I was thinking, I'm going to get sick soon and I'm going to die because I'm pregnant and I don't have a work, and my boyfriend, he doesn't have a work. What I'm going to do? I was thinking about abortion.
And then on that very same day, I was taken to the mother's programs room. That's when I actually began to explore some of my feelings, my fears, and I wasn't so scared anymore.
Helping people, working with people, solving problems, making people feel better. You know, when people crying, you just sit down and say, "Sister, don't cry, you are not alone, I'm here. I was in this. And then now look at me, I'm doing well."
I find the mothers like me. They are HIV positive like me, and they are free. They used to share their feelings, and I share my feelings.
The nurses are the one who are giving people treatment. We are the one who are explaining what is this for.
And I had a healthy baby boy.
I had my child on the 8th of November.
My baby tested HIV negative.
She is HIV negative.
She has tested negative.
He tested HIV negative.
And it was so a relief for me when I was told that after the result that the baby is negative. I hugged the counselor.
Without a program like this, women would die and suffer in silence, especially women.
My life, I think my life is promising now.
We need programs like this.
It helps us a lot, and I want to share all the information to other mothers who tested HIV positive during the time he is pregnant. So I want to share him and give them the hope. It's not end of life.
I'm free now with my HIV because of this program.
And the training that I've got from my mother's program makes me to be more advanced on HIV and get more knowledge and know more things about the HIV and AIDS. So that's why I'm saying now, mother's program is the one who makes me to be able to be so strong as I am today.
These women have been a great help to me. They help me so much. They help me so much. I'm healthier mentally also because of meeting these women. And meeting other women who are like me is even better.
Tula papana musukulila uma moyeza netitana nomntwana. Tula papana musukulila uma moyeza netitana nomntwana.
Yesterday, Yesterday at the United Nations, Babao Mbono, who you saw there singing to her baby, stood up and launched or helped launch the new global plan to eliminate pediatric HIV. It was a launch in front of the world. She spoke first and then introduced Senator Ban Ki-moon, Secretary General Ban Ki-moon of the United Nations, and then followed ex-President Bill Clinton, head of UNICEF. But Baba was on stage representing all the women, all the mothers in the world today living with HIV. Mothers to Mothers as a program, the Mentor Mothers program, is now baked into the policies that will drive PMTCT practice around the world. Thank you.
Well, thanks, Mitch. That's a very tough act to follow. So I'm gonna get up and move around. I talk better if I can use my hands and move around a little bit. At ABC, they never let me stand up because the main anchor is not very tall. And so I'll run into people on the street and they'll say, "You're at ABC News? I had no idea you were so tall." And that'll come into a story I'm about to tell you. But the question of how I got to be where I am today, I never as a kid dreamed that I would be a TV doctor. That was not something I really thought about. I never watched the evening news or the Good Morning America before I was on it. Now I watch it every day. But I got to this job basically thanks to Tom Dashiell's tax accountant. And I'll explain how that happened. It was 2009. And I was the head of terrorism preparedness at CDC. As Ava said, I tend to have impeccable timing. I took that job 2 hours before Katrina hit New Orleans. And it put me in the spotlight at CDC in terms of our response and gave me a lot of practice with risk communication. Move forward 4 years, and it's 2009, and Obama's won the election. And I'm asked to be the acting director of CDC during that transition period until there's a new secretary and a permanent director could be named. And so I'd gotten a call. I was in Israel, actually, when the Israelis moved into Gaza studying their response to, or their preparedness for terrorism. But that's another story. And I get the call, and they say, "We only want you to do this for about 6 weeks. Then Tom Dashiell will be confirmed as Secretary of Health. We'll bring in the new director of CDC, and you'll go back to your regular job." And I said, "But in the meantime, during those 6 weeks, we want you to treat this like it's for real, like you're the real director of CDC." And I said, "Fine, 6 weeks, get a chance to run the nation's public health agency, that'll be great." So I took over the job. The next day I went to Washington and I met with Mark Childress, who was the Chief of Staff in Health and Human Services, to get my marching orders. And I said, when you look at CDC, do you see it in need of minor change, major change, or stabilization? Expecting him to say minor change, he said major change. And I said, "Okay, in what way?" And he said, "For too long as an agency, you focused on low probability, high consequence events like terrorism, like bioterrorism, like emergencies. and you haven't focused on those problems that are killing people today. Diabetes, heart disease, cancer. And he said, you have to shift. You have to shift the priorities. And I said, why in public health do we have to choose between being prepared and reacting to those things now and being prepared for something in the future? You know, such a small fraction of our budget goes to public health. And he said, that's the political reality. You know, there's a set amount for public health, and the balance is wrong. So I had my marching orders. We started working on the economic stimulus, the Recovery Act. We put a lot in there for promoting prevention and good health behaviors. And Daschle imploded. He hadn't declared his limousine rides into the city. And instead of being the acting director for 6 weeks, I was the acting director for 6 months. So April comes along, and I get a call from my deputy who said, I think you need to come to our pandemic flu meeting tomorrow. And we had been having weekly pandemic meetings for 3 years, planning for bird flu. So I came to the meeting and heard about these 2 cases of flu that were associated with swine that had taken place in San Diego, and 2 cases in California. Well, I mean, in Texas. If you're an epidemiologist, you know that, well, one of those events, that's okay. That could occur by chance. 2 occurring that aren't related, your odds are getting pretty low. You got 4 of them, and the probability that there's no connection is just about 0. So I learned more. There had been no connection between these individuals in these cases. There was this big thing going on in Mexico. Hospitals were full. People were dying. Everyone was wearing masks. No one knew what was going on. And I got the word that we might be getting samples from Mexico, and it looked like what was going on in Mexico might be the same thing as we were seeing in the US. So I called up to the department, sent a word up, and said, you know, I think we need to have a call. This is on a Thursday. We need to have a call tonight to talk about this. I think it could be the start of the next pandemic. And I get an email back. We're kind of busy. Do you think it could wait till Friday? And I said, no. You know, I think the White House may need to know about this. We have to have a call. So that night we have a call, and I'm on the phone, and the head of infectious disease from CDC is on. The new chief of staff in Washington. There's still no Secretary of Health. It's the one department, still didn't have a secretary, and it's April. And they get on. The chief of staff up there had been on for a week. There's no political leadership in the department. And I explained that we've got these cases. We think this could be the next pandemic. It's a new strain of flu. No one seems to have immunity. There's people dying at a high rate in Mexico. It looks really, really bad. And she says to me, you know, on a scale of 1 to 10, how worried are you? And I said, 8. And there was this pause, this dead silence on the line. And she says, an 8? I said, yes, an 8. I think the White House needs to know. And that kind of kicked off our response to the flu. The next day we had activated our emergency operations center, the White House held a press conference, and we got rolling. But I got off the call, and the head of emergency operations at CDC, he called me, and he said, an 8? He said, this is probably a 6. And I said, it's all about communications and what you want to accomplish with your communications. And I wanted to get their attention. A 6 would not have gotten their attention. An 8 was definitely what it took. So the next day when we met and we talked about our strategy moving forward, one of the things that we decided was that communication was going to be a centerpiece of our response. Often in public health, and in a lot that goes on in government, communication takes a back seat. You do what you need to do because you're saving lives. Communication comes at the end. And because of that, you can run into real problems. So we decided that communication was going to be central. We were going to not turn down a single interview request. If a reporter had a question, we would give them an answer. We would hold press conferences at least once a day, if not more frequently. We wanted people to trust the CDC, get their information from CDC. We followed basic principles of risk communications. We wanted to be first, be right, and be credible. We wanted to tell people what we knew, what we didn't know, and what we were doing to get answers. And that began what was one of the more successful communication strategies that we've ever had in public health. And we were doing surveys of the public, and we found over time people's faith in the government at that point, in the early part of the response, was going up. It was over 80%. which was very unusual, that people trust government to do anything at 80%. So while we were working on the public communication strategy, we were also doing a lot to focus on communication with leadership. Because if you don't communicate well with the public, you lose their trust. If you don't communicate well with the political leadership, you lose their trust. So the next week, we finally got a Secretary of Health, Kathleen Sebelius. And I was invited to Washington to brief the president and the cabinet. So get on the plane. I bring my one press guy with me. We head up to Washington. We meet Kathleen Sebelius in her office. She'd been on the job for 2 days. We'd been talking a lot before she was confirmed. And so I come in, I say, okay, we're going to brief the president. Can anyone tell me how you brief the president? And we all look around the room, and they say, no. And I mean, that made sense. They were just new on the job, too. I said, well, how long should I talk for? Because I can give the same talk in any length. I can give this talk in the 1-minute version or the 3-hour version. They said, 7 minutes. So I mentally prepared for 7 minutes. I went with the Secretary of the White House. We go up through the West Wing. We go into the cabinet room. And there's everybody milling around that I've been following in the news for years. These were all the people who had run against each other. There's Hillary Clinton. They're all there. And I thought the cabinet met like every Thursday. They get together, they have their meeting, and they go on. This was the second meeting of the cabinet during the administration. It was 100 days into the administration. It was the first meeting with the full cabinet because Kathleen Sebelius was just confirmed. And so we sit down, and the president welcomes everybody. He thanks everyone for their service during those 100 days, tells everyone they need to take a little more time with their families. You can tell that no one knows that's going to happen. And he says, I want to now turn it over to Dr. Besser. So I give my talk. I stick to my 7 minutes. And he turns to me and he said, that was a perfect briefing. And I don't remember a thing he said after that. So we get to the question and answers after that. And the only person I was worried about was the Secretary of Energy, because he has a Nobel Prize in science. The rest of them, Hillary Clinton said, so what's the difference between pandemic flu and seasonal flu? And I couldn't have asked for a better question. Because what it told me was that political leadership is just like the general public. They don't know anything. And you run into a problem when you're a technical person in government and you treat the political leadership like they're technical experts. And so I basically explained to her, just the way I had been doing at press conferences, the difference and why you needed to worry. And so the questions went on. Then the meeting broke up, and I'm not going to go to that story. But I have to tell that story. So the meeting broke up, and there's Vice President Biden. He says, Rich, I need to talk to you about a meeting I'm going to. And John Brennan, the National Security Advisor, says, Rich, I need you right now. We have a call with 50 governors. We need to talk to them about what we're going to do. And Kathleen Sebelius says, Rich, I need you in Rahm Emanuel's office right now. The Department of Education is really upset about the school closure guidance. And I'm thinking, where do I go? I'm hoping that maybe they'll ask me to be CDC director, so I'm thinking I have to go with Kathleen Sebelius. But there's Biden, right? And the day before Biden had gotten on the air, he was talking about something economic, and someone asked him, Mr. Vice President, is it safe to fly? And he said, I'm not getting on commercial planes, and I'm telling my family they shouldn't either. 30 seconds, I think, after he made that, my beeper went off in Atlanta, and they got me down to the studio to fix it. And so I got on, I think it was MSNBC, and they said, let me show you this clip. The Vice President said it's not safe to fly. And I said, well, we call this in public health a teachable moment. What the Vice President meant was that if you're sick, you should not get on a plane, because you're likely to spread it to other people. But for everyone else, it's safe to fly. And so when he had a question after the cabinet meeting, I'm thinking, I better go answer his question. So I dealt with his question, and then I went back with Rahm Emanuel, dealt with their issue, and then I got on the governor's call. moving forward in time, the outbreak continued. The CDC, the secretary named a permanent director of CDC. And I started to look for, well, what am I going to do next? And during this time, when I was on television a lot, a couple of the television networks had reached to me and said, you know, we'd really be interested in talking to you about a job if you ever decide to leave CDC. So I was looking at all kinds of things, jobs in education, with foundations, other public health jobs. But nothing struck me as more interesting and more potentially challenging and potentially impactful than trying media. And having a platform where every day I could talk to maybe 12 million people about public health. So I took the job at ABC News. I've been here for about 2 years. I've been in a lot of cross-cultural environments, and I think that none is quite as challenging as going from public health to ABC News. What drives us, why we're there, is a little bit different. At one point, I made the mistake of saying, oh, it's only television. And that didn't go over very well. But it's true. So I've been at ABC for about 2 years. When I first got there, we were able to get money from the Gates Foundation for global health coverage. And so this past year, I've had an opportunity to travel the world and tell stories that I think are important. Stories about public health problems that you tend not to see on television very often. And hopefully by doing that, to change the way the American public views public health and views issues around the world. But it's been a lot of fun. I went to Africa in March and shot 3 stories, one on meningitis, one on pneumonia, one on the sweet potato, and one on female genital mutilation. So far, I've not been able to air, I've been able to air one of these stories. The others hopefully will come during the summer and early into this fall. But it's a challenge. You know, I may be on one morning talking about why a mother is giving her 8-year-old daughter Botox, right, which I don't think is a major public health issue. So this story is a story about meningitis. As a pediatrician in training, and Jamie, you'll know this as well, we saw a lot of kids with meningitis. But it's very unusual to see children with meningitis today. But here in this setting in Burkina Faso, meningitis is something that is a reality.
All year long, ABC News has been focusing on global health and how easy it is for you to save a life. The latest segment in our Be the Change, Save a Life series, sponsored in part by the Bill and Melinda Gates Foundation, looks at a disease few kids here in the U.S. encounter. Dr. Rich Besser is here with more on that.
George, when you train as a pediatrician in the U.S., there's some diseases you just don't encounter. Devastating infections that I treated when I trained and when I lived abroad. But I'm about to take you to one of the poorest places in the world and show you that a whole country is on the brink of saving the next generation of their children. This beautiful girl knows the danger of bacterial meningitis too well. You'll soon know why she's laughing and why her whole community is safer today. In a world without meningitis, there are castles and happiness. In a world with meningitis, devastation and a scorching sun. Here, mom and dad take their baby to a hospital on a bicycle. One shot would have helped these children. All death because meningitis damaged critical nerves in the brain. In her drawing, a boy cries. In sign language, she tells us, he had a fever, and the diagnosis was meningitis. Here in the city of Ouagadougou, it's the hot, dry season. It's 106 degrees in the sun. This is the season when meningitis strikes, and mothers live in fear. But this year's different. Take a look at this ward. The beds are empty. Not a single case of meningitis here. You want to see determination? Watch one man lead a medical army, getting 11 million people the shot in just 12 days.
Some people would say in the middle of nowhere, but it's in the middle of somewhere today.
I found him in Burkina Faso. Since I met him 8 years ago, he's been obsessed with meningitis and the particular strain that strikes only here in sub-Saharan Africa. This is the first vaccine made just for Africa. I mean, this is really a game changer.
Widespread use of this vaccine should eliminate meningitis epidemics that have occurred in this area for decades.
It took 10 years. Technology from the US FDA, raw materials from Europe, manufacturing in India. This vaccine would cost $100 in the US. They made it for 40 cents a dose. Mark LaForce knew that was all Africa could afford. They got the first shots in December. Now,
when you get up in the morning, in the height of the dry season, and you're not hearing about meningitis, how does that feel?
Oh, it makes me feel just incredibly elated. And to be here at exactly this time, this is transformational.
Rosalie Wadraogo knows that if meningitis is conquered in Africa, she can only tell her children through sign language. Florence was just 6 when it struck. 3 years later, it was Xavier. And finally, Diane. All deaf and disabled by a disease that can now be prevented.
Where is your husband?
When the children got sick, he left me. The family lives here in this single room with no electricity, which means at night, no one can see their hands. So Florence, now 22, has one particular dream.
Yeah. So you want to be an electrician. If you're an electrician, will you bring electricity to your home? That would be wonderful.
Until then,
this is a flashlight. Oui.
Thank you, thank you, thank you. I just want to point out I gave Florence and her family wind-up flashlights so they don't have to worry about changing batteries. And we've been hearing great news out of Burkina Faso. The dry season is winding down now, and they've only seen 4 cases of meningitis for the whole season. And those only occurred in people who did not get the vaccine. George, this offers incredible hope to the 22 other countries in the area that are still waiting for vaccine.
4 cases, so they've come so close to eliminating it.
Normally see thousands. 4 cases this year.
That is fantastic. Be the change, save a life. Thank you very much, Rich Besser. You can find out more how to save a life. Head to our website at abcnews.com/GMA. You can also follow Rich on Twitter.
We have a few minutes, and we'd love to have any questions. Yeah. Yeah, the question has to do with successful communications and the lack of uptake for vaccine. How can those both be true? And I think that early in an outbreak, early in a new emerging infection, you don't know how severe it's going to be. And had this been like a 1918 flu strain, I think that the big issue would have been vaccine shortage. People would have been lining up to get this. As more became known about this virus, that it wasn't as severe as many seasonal flu strains, there was a bit of a backlash. And as vaccine wasn't available early on, there was a backlash. There is a growing sentiment in the country of vaccine hesitancy as well as fear of vaccines. And the media, I think, has fed into that by, I think, this kind of fallacy in TV journalism that a fair take on a story is always having one person on each side of an issue, even when at times the science is 98% on one side. It tends to give more credibility to some issues than there should be.
Yeah, I think that several things are happening. We're trying, there are many efforts going forward to train more healthcare providers. And doctors and nurses need to be trained. They need to be retained in the country. In South Africa, 50% of the doctors that have been trained in the last 15 years have left. But I think there's also an appreciation that there's some aspects of medical care that shouldn't be delivered by doctors and nurses. The kinds of efforts that educate and provide support. First, the kinds of behavior change that we're trying to drive aren't best delivered by doctors and nurses. We're not, frankly, trained to do that kind of work, and we don't have the time. And so that what we're trying to promote is really a redefinition of what constitutes a healthcare team. And it's more than just a doctor and a nurse. We certainly need more of them. There are more schools opening up to train doctors and nurses, but there's also the recognition that, you know, in 2 short weeks, you can train a healthcare provider who can provide the education and support that drives behavior change. And that really is how best healthcare services should be provided, not just in relation to HIV, but even in this country, where we're trying to get people to you know, sort of to act better, to live healthier lives. And so that really it's how do we better define healthcare service provision?
You want to do stigma?
I'll do stigma, you do parents.
Okay.
Well, there was a question about stigma, and there was a question about parents. I'm going to do stigma, he's going to do parents. Stigma reduction. You know, stigma reduction comes in small steps. And it's about changing the way women, often the way people perceive themselves. The kind of stigma which is often so disabling is the way we stigmatize ourselves when we have conditions. And, you know, the first step is really enabling mothers who are living with HIV to appreciate that they can live what we call live positively. You know, by virtue of putting mothers together who are living with HIV, they build there's a new sentiment that they have power, that they don't have to be victimized by their families, by their partners often. And also, so that's women in general. By employing women, by giving them a salary, by not making them dependent any longer on their men, that changes the whole perception of what it means to be a woman in Africa, which needs to change, and also what it means to be living with HIV. So that very often our staff are viewed as a community resource, and people come to them in their homes. And what happens over time is these kinds of changes in attitude generate change in communities, and as you bring together more communities that feel differently about HIV, that changes the way nations perceive HIV. So we have a long way to go there. But I think in small steps, changing attitudes about oneself, changing attitudes in the people around you will generate, you know, large-scale change.
So the parents. We grew up in a home where giving back to the community was something that was viewed as important. Our parents, for many summers, would go out to an Indian reservation, usually Navajo reservation, and work. Our dad, obstetrician gynecologist, our mom's a social worker. So they would do that, and we'd both been out there. But also as kids, we were both exchange students. We were foreign exchange students, and that kind of changed the scope and the sense of what's possible. Yes?
It's a great question. We know that breastfeeding, the question was, what's the incidence of breastfeeding transmission at this time? And it's a complicated question because we know that breast milk is infected with the virus. And we also know, that mothers can infect an HIV negative baby, a baby born HIV negative, by breastfeeding the child. But we also know that the best food for babies is breast milk. And the babies that aren't breastfed, that are formula fed frequently in Africa, die of respiratory illnesses and diarrheal illnesses. So there's this terrible dilemma that mothers face about breastfeeding a child at the risk of infecting it with HIV or formula feeding it at the risk of it dying from diarrhea or respiratory illnesses. What's happened in the last year, though, is new medicine. And that we know that if a mother is taking antiretroviral drugs while she's breastfeeding, or if you can give a baby a single dose of antiretroviral medicine, a bit of syrup every day while it's breastfed, it's protected against being infected. And the transmission rates are down around 2 out of 100, 2%. So that while breastfeeding used to be high risk, it's now low risk. And we can very safely promote breastfeeding amongst mothers if we can ensure that they or the baby get the medicine. And this has been a game changer in terms of promoting all the other issues around, that we want to promote around breastfeeding practices. Thanks.
I think we're out of time, but thank you all very much for coming, and we'll be around.